Then after that, she flat on the floor. Then she also explained to her that she will take the baby 3 times. And in between, she should not talk during and in between the measurements. And in the counseling aspect, she counseled her very well. And both of them understand each other. I think she did a very good work.
Thank you, ma'am. Okay. Further reactions? What did we observe? What did we observe? Good afternoon.
What I observed is that she has observed all the protocol that is supposed to observe during the taking of blood pressure. She explained it very well to the understanding of the clients, and the clients responded well. So she has done it well.
Thank you, ma'am. Please, one more observation so that we'll go to the next presentation. Yes, ma'am.
Good afternoon, everybody.
Good afternoon.
Please, I want us to be on the same page. It is about this Maggie and salt in the UK. So I want to ask the salt and few cubes of Maggie to cooking. Is it not good, or should we suspend salt totally and go on? Or should we suspend Maggie
I think we should put a little salt, then add a little Maggi. Yes, you cannot put only Maggi and leave the salt. At least a little salt, then you reduce the quantity of the Maggi. I think that's the best thing to do. The doctor is here to tell us the final observation.
In the market, we have various companies coming out with Maggi. And for us in the kitchen, we are very much aware of the fact that some Maggis, I would say this, are invested with too much salt. They are over-condimented more than others. I don't know if I mentioned something there. Too much salt in it. But if you go for it, mama pot like that, if you don't even see it in the market, those ones are a little condimented. So we think not actually to exclude salt in our meals, but to go for the other one that are less salt. Thank you. Doctor, over to you.
Thank you very much. So the Maggi cubes, they contain much salt, concentrated salt. The quantity of salt in different times they differ. And from the what we call front of packaging, we tell you the quantity of salt. Because actually before you buy any product, you should look at the quantity of salt in that front of packaging. They will tell you. You will know the one that contains more salt than the others. You know about Ajinomoto. It contains a lot of salt. There are some that contain less salt. Now we say that every man needs salt. What we are saying that excessive salt. Maggi contains salt. The salt you are putting is salt already. So it is possible for you to use one. It is possible also for you to use little of both. But the important thing is that what is the quantity of salt in the one you are using? That's very, very important. So what we say is this. use salt in moderation. If you are using Maggi and salt, it means you have to reduce the quantity of both, but both of them contain salt. If you are using wine, use one. And we have spices that are not salt, local spices. It can improve the taste. And let me tell you what is maybe will happen if it's case true. Maybe with WHO, with a lot of countries, there's now what we call salt substitute. So they are replacing part of it. No salt is sodium. You know, when you consume too much salt, you attract more water. The blood volume is more, the blood pressure is going to be higher, and there will be more stress to the heart. Sodium, excess sodium increases blood pressure. Potassium reduces blood pressure. So there's what we call salt substitute. So there is some sodium, then you replace the other part of it with potassium. So you're going to balance it out. You need sodium, but you don't need too much of it. We need potassium. It's very, very good for our body. I also need it in moderation. So you are using both. Because potassium reduces blood pressure. That's why we talk about fruits. We talk about vegetables. They contain a lot of potassium to reduce blood pressure. So there is what we call salt. People are selling it already. It's more expensive. It's not much in our market, but I believe we get there. So what is the message? The message is salt should be used in moderation. That is important. If you are using Maggi and you are using salt together, you must reduce the quantity of both, because both of them are salt. Then the other one is don't add salt on the table salt. Now, if you are in a home and they cook food and you are the only one complaining that there is so much salt, know that you are the one that has the problem. You understand what I mean? And the issue about salt is this: with time, your taste bud can get adjusted. Are we following? Can get adjusted. So it's a question of discipline, a question of education, your taste bud. I have patients that will tell me that they don't add salt to their food. You know? And I said, how does it taste? They said they are just comfortable. They've gotten used to it. So remember that even the natural food you eat, the yam, the cassava, even this water contains salt. You know? Water, there's natural salt in every food. God has made it so it already contains salt. You just add a bit, you understand, to meet the body's requirement. So we need salt to function, but excessive salt is not good. So if you want to use Maggi alone, it's possible to use it alone. If you want to use salt alone, it's possible. If you are going to use both, then you must reduce the quantity of both, because it's salt. I hope that has answered the question. Or hopefully with such substitute, you know, when they come more into market, that is better for us. So sodium level is reduced, replaced by potassium. Potassium, you need potassium if you reduce the blood pressure. So if you can counteract anything with sodium, and you have also reduced the balance, the level of the sodium. So how do you do for advising people about salt? One thing you must tell people is that in moderation, put it in such a way that nobody complains of feeling the taste too much. If any person complains that this your food is salty, you use that person as a standard. Number two, if you are using Maggi, you must add salt together, you must reduce both drastically, minimum amount. Number three, don't leave salt at the table when you have cooked. If it's not salty to you, manage it that way. It is better for you. If you have problem, there are some natural spices that are not salty. if you have problem of taste, because one problem of salt is taste. And of course, people know how salt came about. Salt came about, people in Greece, you read the story of salt, that they were giving them food that are not, those spices, not in bland food, and to make it tasty, they started adding salt. That's it. That's how the salt story came about. So salt is not something that was naturally designed, but along the line, our taste buds are not used to it. So can you use new and other natural things to help your taste buds? It's possible. And anybody can adjust. So you keep on telling your patient that anybody, there are people that don't take salt and they enjoy the food. Because along the line, they have adjusted it. If I give you 1 year, there is no other food you can get. And we give you food without salt. We can't get used to it. I tell you, human beings can adapt. Yes. But that adaptation, that is what is difficult in the first place. So there is, you can do it, you can reduce or you can tell you, keep on passing to reduce the amount of salt. But remember that we need some salt in our body to function. And some of them already there in the water you are taking and the water. I hope I've answered the question.
Yes. Okay, I have a question. I just want to know is that can there's this thing that is trending in social media. Advocating to women that we should stop killing their prostates. Does it affect? Now we're having cases of prostate enlargement and cancer.
Well, yes. Thank you very much. Like I said, there are different types of all these opinions. Like I told you about Moto and things like that. For most cancers, nobody knows the cause. And people have been attributing some of the cancer with a lot of chemicals and things like that. So that's why they are talking about that. Eat natural as much as possible. That's the important thing. As much that you can avoid anything that is not natural, avoid it. It's better to avoid than to fry. It's better. So as natural as possible, it's better. So that's the advice we keep on giving people. That our forefathers lived longer, most because they were eating directly from the farms. Their things were natural. They were not stored. They didn't have preservatives storing them. But the truth is that nobody fully understands what causes cancer, but we're saying now that it's possible that the chemical that people are exposed to is making them become a type of diet. That's why they are talking about such things. So it's better to avoid anything that is those synthetic things as much as possible. So I answered your question. Okay? We should continue. Okay. You're the
Yes, sir.
I need to come along after some time. Okay, so we're going to be talking about treatment of hypertension. Look, also before we start, because this is going to be just an overview. Who are the community nurses here that are treating? Let's raise up our hands well. Okay, good. So can you share your experience with us, madam? Any experience, anything you want to tell us? How far? Has it been good? Has it been bad?
Yeah.
Or have you had some challenges? Okay, maybe you can do this.
Well, first of all, I want to thank you for this intervention. Because our clients, after a while, one will just be reported as dry
diabetes, you know, so this treatment has really helped. So it's a good one, and we want to thank you and ask you for it.
Alright, thank you. So you are saying that before some of them were dying of stroke, even after they are and then you think maybe it's to the HIV, and that is the truth. As people live longer, their blood pressure will increase. Whether it gets above normal or not is another thing. But as people live longer, they are living longer, so their blood pressure will be high. And then there is risk of stroke, heart failure, kidney disease, and so on. Any other person want to share your experience with us? Yes, the nurses. Thank you. I'm not hearing you. Thank you very much. Thank you. So you gave the person amlodipine 5 milligrams, so you're very right. So 150/80. So the first step. One of the side effects of amlodipine is headaches. You understand? So headaches. So what do? The headaches are more when you start it. Outside the protocol for them because they can't tolerate what is in the protocol. Hope you understand. So for such people, even using half moderatic is just enough for them. Not full moderatic or half can just take care of their blood pressure. Half can of moderatic because they cannot tolerate the amlodipine. But amlodipine with time, even the headache will just stop. That's just my first dose. First time exposed to it. Another thing amlodipine can cause in some people is leg swelling. And the leg swelling is not anyhow, there is no harm with it, it's just cosmetics. Few people can have leg swelling with it also. So you just counseling your patient and making them know that such side effects are part of what with amlodipine can happen, but it will go off with time, especially the headaches. Okay, can we continue? Okay, let's continue. So we're looking at treatment, and by now you have your protocol. You have it there? Yes, good. So please, I have the protocol. But we'll get to it later. But let us see why do you treat a patient. These are some of the reasons why you treat. Why treat hypertension, So this is the outline why we treat. So I'm going to give you some of the reasons why we treat. Aims of treatment, which will be screened and so on and so forth. So this is not new. So why do we treat? Hypertension is the leading cause of cardiovascular disease like stroke. Stroke, heart failure, kidney disease is the leading cause. High blood pressure is the leading cause. So we say it drives cardiovascular disease. If you take care of high blood pressure in Nigeria, most of the heart failure, 60-70% of the heart failure you will not see. About 30 to 40% of the kidney disease will be taken care of. Over 90% of the stroke will be taken care of. Are we following? So that's why we treat. And one thing about high blood pressure is that by the time it's increasing by 20 millimeters, it's systolic. Which one is the systolic? The upper or the lower one? Okay, good. And that's systolic by 10 millimeters and above. Wow. 10 millimeters and above. Then there is also a risk. So putting the blood pressure at normal, and what is normal now? What do you say is normal now? You said? No, normal. What is normal?
120/8.
Yeah, 120/8 is normal. What is the cutoff we're using? 140/90. That's what we're using. So 140/90 should be less than 140/90. So 140/90. So, and if a patient has HIV, he has hypertension in addition, then the risk increases. I will explain. The risk of this damage to the heart, damage to the kidneys will also increase. So, and that is why we keep on emphasizing these patients that have HIV, they have to be, and hypertension, they must be treated. Otherwise, the risk of them having a stroke can be quite high. So all over the world, I want you to take note that high blood pressure is the leading factor for stroke, for heart failure, for kidney disease, what we call cardiovascular disease. So if you take care of hypertension, you take care of a lot of problems. Now, hypertension is responsible for about 17 to 18 million deaths every year all over the world. And if you do it through stroke, through kidney disease, you can see that the problem of hypertension is high. You see people in community. You saw it yesterday. What has happened? A stroke. So people have a stroke and die in their sleep. And because you don't do postmortem, you know what people will say? They say they reach superstition, you understand? Or some of them is just blood pressure. So if you take care of blood pressure, you reduce a lot of these sudden deaths. So you reduce mortality, So if you get to a community, so you are doing community work. For example, you see 100 people and you treat those 100 people and you manage to reduce their blood pressure. Maybe the blood pressure was 150. You manage to take it to an average 148. You are going to reduce heart attack by about 7%. You are going to reduce stroke over 10%. Just community approach. So the work you are doing with this community, you don't know the level of what you are doing. They are prolonging life. Some of them maybe by now will have had a stroke, by now, but you are just helping them. Are you following the intervention? Prevention is better than cure. So that's why you must realize that what you are doing is very, very important. Are we following? Please, what you are doing is very, very important. So, in hypertension, what are we supposed to do? I have said it before, screen every person 18 years and above. 18 years is because that is the adult age in Nigeria. By 18 you can vote. Is that not true? Yeah. You can drive adult age. Some countries we say 20. Some countries take it to 16, lower than that. So you do that. So please. And if the blood pressure of that person is elevated, what you can do is that if it's not too high, you can say come back. Take for example, it's 142/92. It might be due to the fact that the person, that elevation, might be due to the fact that the person has malaria, for example, anxiety. You can say come back for the screening. But if you take it and the blood pressure is 200/120, are you going to tell the person to come back? If you tell the person to come back, it might be a cost. So for such a person, what do? If you say 200/120, say? Yeah. You take, yes, you give some, you can give some doctor and refer. Go to the last step and refer, you understand? But please, you have to refer surgery and refer urgently to get back to before then, give medications and refer. Some people will say, I won't go. Are you following me? You can't force them. Is that not true? But it is written that you are referred. And when they come back again, and they be taking their medication, because I've noticed such people, that pressure begins to be controlled. You are not going to say, send them away and say, no, we have referred you. Because it is documented. And you must write that they have refused to go where you refer them to. Are we following me? Yeah. So that is very, very important. That you must know when to say, come back. You don't say, come back when the blood pressure is 180/120, 180/110. Come back, I want to check it in 1 week. To be serious. I've given this story before that one of our drivers in the teaching hospital had the blood pressure about 180/110. And someone that saw him gave Valium and said, go and rest. He came back the following day with stroke. I'm sure. He came out with stroke. Thank God today it's working, but you know that there's had a stroke. People have been prevented. So please, let us take note of this. We do what is. If you are not sure, what do? You call. You say, no, I have this patient, what do I do? You call. In that way, you can offer the test to these people. So, and you cancel them also. Tell people they should know their numbers, cancel them about diet, like we have been looking at it. Try to take vegetables, try to take fruits. So if you have money, for example, to buy soft drink, use the money to buy fruits. You know, some people say fruits are expensive, but you are taking soft drink. You can use that money for soft drink to buy fruits. So those are some of the things you tell people. Then the other thing you must take note of is the fact that you must know when to treat. So if the blood pressure is persistently 140 millimeters and above, then you can treat the patient. 140 and above, persistently and above. So what we are saying is that one often he has come 142/92. He was rushing when he came. You can tell him to wait. You can tell him to go back. He's in that community and come back. But by the time the blood pressure, every time you repeat it, the blood pressure is still 140 and above, 90 and above, then you know that this is hypertension. So hypertension means that it must be persistently elevated. If you took it before 144/9 and you take it again 130/80, you take it again 130/80, is that hypertension? No, it's not. So it must be that persistence must be there for hypertension. So we have different classes of drugs, and this is where we are going to very soon just go into what we have in the simplified protocol. So maybe we can just take the simplified protocol, we'll go through it. Now, can I have one? So there are different classes of drugs. There's what we call calcium channel blocker. Which of them, which an example, what an example of calcium channel blocker? Amlodipine is a calcium channel blocker. There's what we call angiotensin converting enzyme inhibitor. you know an example? Say, no, angiotensin converting enzyme inhibitor. No, losartan angiotensin receptor blocker. Lysinoprid, angiotensin converting enzyme inhibitor. Then there's angiotensin receptor blocker, that's losartan. And there's what we call diuretics. We can qualify it as a thiazide diuretics, that is hydrochlorothiazide. Are we following? Hope we are following. So, now, the three main classes, or let's say four main classes of antihypertensive medication that is being used in the world today are calcium channel blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and diuretics, especially thiazide, or what we call thiazide. So, we have the classes. The only problem about angiotensin converting enzyme inhibitor, what we don't normally promote it in the primary care is because it can cause dry cough. Are we following me? In about 5 to 10% of people, they will start dry cough. Dry cough, nothing, it can be so irritating. Number one, that's one thing. Lysinoprid, angiotensin converting enzyme inhibitor. And the second thing about this is that some patients can react 1 to 2%. They have swollen lips. Their lip will swell or their tongue can swell. So, in the primary care, we want to avoid anything that will give you such side effects as much as possible. Because if someone in the primary care, the lips swells, it will discourage other people. You know, there's a way you spread. He said, when that nurse gives you drug, your lip will swell. Run away from her. It's a dangerous woman. Or they send a drug in that place. Any drug they give you, there's reaction. So we are careful. That is why we use losartan instead. So losartan replaces that lysinoprid. Lysinoprid is cheaper, but losartan replaces it. You said no. No, never you use the two at the same time. Do you understand?
Yes.
Can we continue?
Yes.
Now we are basing what we have here, and I'm telling you the rationale for what we have here. So please, let us take proper note. So, blood pressure, you can see the step one. Step one is to start with what? Bloating. When you have confirmed that the person is hypertensive, and what is hypertension? Who can tell us again? Yeah. Persistently, that must be there. Persistently above. That must be there. So please, let us take note of that. After 1 month, we are going to review the patient. If the blood pressure is less than 140/90, what do? You do what? You continue. Good. So you continue. You don't change the winning team. If the blood pressure is still above, is 140/90 and above, what do? You go to what? Step 2. You go to, and that look at step 2. 5 milligrams of amlodipine and 50 milligrams of losartan. Remember that we did not say that step 2 is 10 milligrams of amlodipine. I will follow you. And I'm going to tell you the reason for that. Because if you have increased to 10 milligrams of amlodipine, the side effect of amlodipine will also increase. Is that not true? One of them is headaches, you saw. Another one is leg swelling. But by the time you add 50 milligrams of losartan, in fact, it takes care in a way. They work complementary in a way to even take care of the side effects. So, 5 milligrams of amlodipine and losartan 50 is far, far better than 10 milligrams of amlodipine. Are we following me? Are we following me? So you don't go to the maximum doses. You have to add something. help the efficacy. So after another 1 month, and the blood pressure is still not less than 140/90, you double. I'm looking now 10 and the Satan 100. Yeah. Because I'm looking at doubling, you're also doubling the Satan to follow. And after another 1 month, that is the time you add hydrochlorothiazide to it. I will say that. And for patients, of course, that your blood pressure is above that 180 over 110 and above, you are going to refer. You can give them medication in step 4, and then you do what? You refer. And I've told you that if they say they are not going to go, they can continue. But you have documented that you refuse to go. So please, let us, follow this algorithm. It is very, very good. And I want to tell you that if you go to the WHO website, this is recognized. Are you following me? So this is recognized. Yes, so any question? Yes.
One of the questions that we have in the pre-test, blood pressure is 80/40 something. I can't really remember the number. So in that case, what should we do?
Good question. If you continue, that patient can die. You don't continue. 80/40, you stop. You don't take the medication and you refer. Possible. It's better. You seek advice, but you stop. Patient does not take the medication for 80/40. The limit has to make it.
The option that they gave us, they said one of the options was stop and leave the appointment, close the appointment, or you do alternate days.
You don't do alternate days. We can stop. See as soon as possible. Stop and see as soon as possible, because you have to evaluate. Why is the blood pressure of that patient like that? Is it because he has a fever? Is it because he has a diarrhea? Is it a problem? You understand? You have to evaluate the patient. So, any other question? Yes. All is it on the 80/40? So that no for you.
Another value.
Okay. All right. Good. So another question.
I know this one is not in our field, but I just want to have knowledge about it.
Yeah.
I went to teaching hospital. We saw a client that was having stroke, and they gave the client normal salary.
Yes.
The normal salary is so I was confused.
Yes.
So I want to have
Good question. So, for stroke patients, we normally use normal saline. We don't want to use dextrose saline because the dextrose just simply goes into the tissue and draw more water and causes more fluid. You understand? Even if you are going to use dextrose, we have some saline in it. We want something that can remain in the intravascular space. But then, these are patients you monitor the fluid. These are patients that you also have to place on antihypertensive after some time, so it balances out. But you really, yes, it depends. Yes, they won't immediately. When who has stroke, there's a level of blood pressure we give antihypertensive immediately. We have to monitor because the brain has gotten used to very high levels. So if you are giving antihypertensive, you might be causing more problem. Because when the person has stroke, a part of the brain has died, or there's area around it, which if you are not careful can die also, and the condition worsens. So you want to preserve that area. That's why you don't give antihypertensive immediately. Yeah, you have to preserve that area. It's only when the blood pressure comes to a given level, it's okay. You must just give small, and you have to be careful the antihypertensive you give. Yes, sir. And that's why we're going G2 feeding and instead of giving them food. Yes.
So this one has to do with another value, what lower again. Maybe like 160, 100. 160, 100. And then that's the patient gained control.
Before?
Yes.
And
For like
after,
6 months
yes.
or more.
And after a time, the blood pressure.
So, will it be responsible? What do you think will be responsible? Is it that the patient did not adhere?
Yeah.
Or is it that because there was a high high blood pressure control.
Yeah,
That's
before.
where my concern.
Initially it was controlled and later it was
controlled.
not controlled yet.
Now that in some months' time, maybe
Mhm.
like reasonable months, like 6 to 8 months, patients eating went up.
Yes, so what has
What
happened?
could be done?
Good.
Because I wouldn't be in a hurry to move to another step.
Good.
I have to find out whether there was adherence.
Yeah.
And if there was not, should I continue with that same step?
Good question. So, a lot of things can be responsible for that, you know. A lot of things. So, a patient has had a control before. Or what is the patient taking? Is the patient taking the right drug in the first place? Take, for example, if the patient was supposed to be on step 2, amlodipine and is taking 10 milligrams of amlodipine, you can have that problem. Because we are using monotherapy, we are using one. But if the patient is on the right drug, it was controlled, and after a time it was not controlled, there are different things that happen. Maybe the patient was getting tired of the drug, and compliance is a problem. 2, has he changed his lifestyle? Is he someone that drinks and is drinking much, is smoking? Has he added some weight? Is he taking more salt? So there are a lot of things that can be responsible. So that patient needs counseling. So you are not in a hurry, I agree with you, you are not in a hurry to go to the next step. You have to, but when the patient tells you, I'm taking it and everything, it is possible. Because with time, people can require more. So if you are sure and the patient, you can move to the next step or cancel the patient first. You are not in a hurry to move to the next step. Cancel it. Are we following? Okay. Like I saw a patient one time, quite some time, he's the top officer in the Air Force, and we're battling with the blood pressure, controlling the blood pressure, until he started lifestyle to lose weight, to drink less, and things like that, and his blood pressure started getting controlled. So lifestyle is very important. The more weight you have, the higher the blood pressure. The more alcohol you consume, the higher the blood pressure. The more cigarette you take, the higher the blood pressure. The more salt you take, the higher the blood pressure. So lifestyle, you cannot overemphasize. But the truth is that most people are not just controlled only on lifestyle. Yes, they need some form of medications. Okay? Any other question? Are we following?
Yes.
Now the meat of this is revision to be sure you are comfortable with this protocol. Please, you must be able to use it. At this stage there should be no mistake in using the protocol. If you are not sure, you ask. Some dicey situation can come, ask. For example, Madam mentioned that the blood pressure was controlled before, and after a time it's not controlled again. That's the type of patient you see that cancel very well and know what has happened before you go to the next step. And you will document that you cancel the patient says he's taking the medication, or you cancel, patient is not compliant, and he has promised to be compliant now after canceling. Any others? Say what? Yes. No. I want to emphasize the one that concerns you. And that is so. That's what we call this centrally beta blockers. It's not for this level. Don't worry. Use the protocol. That's what you want to do. All those arguments, all those we don't use them again. Yes, question. continue with your that step here. You don't change a winning team. You understand? The only time you keep on, you consider and you must seek advice whether you can go is if the patient blood pressure is falling, say below 100/60, and the patient is dizzy. Are you following me? It's complaining of dizziness. I get up, it's as if I'm stabbing. Then you have to consider that, okay, can we de-escalate that is good down to it? But such patients have to be seen more, say you give like 1 week appointment or 2 to follow. Yes. Yes.
And persistently higher than 140, not up to 170.
Yes.
Should the primary health worker suggest that the client should please go have cholesterol, uric acid, also
Okay, thanks, yeah. Okay, yeah. So that's a good question. Something is this, in the primary care, let me know we don't have such facilities. And what the PHC is teaching is that it is better to treat, and if you can't investigate, than to say you won't treat because of investigation. And it's better to treat before you, because you use all the money to investigate, and there's no money for treatment. You know you have done nothing. But if the patient can afford it, you can go. But if you afford it and bring it, but that has to be interpreted by a doctor. You know, yes, by a doctor over this, you have to be interpreted. Are you following me? When they have it, no problem. But if they don't have it, it's better to just treat them. Because if you wait, somebody investigation now, by the time you do electrolyte urine creatinine, fasting blood sugar, they are about 10,000–15,000 naira. They are not cheap. And you don't have the facilities in the primary care level. The only thing you can do in the primary care level is that can do some urinalysis. It can help us. Then some people have glucometer, yes, to do a blood sugar. Can help us. So, yeah. Yeah, if he has it. Why not? Good. Why not? Why not? Yes. Why not? If the patient has results, you put it there. But we don't force them to do it because they will spend a lot of money doing it. But if they can afford it, it's good. Okay? So are we flowing? So there are some I left just for if you want to read further and things like that. These are just if you want to read. If I have like a diabetic patient, the cutoff is not 140/90. It's less than 130/80. If I believe in diabetes, yes, because hypertension and diabetes, when they combine together, they do more damage. Are we following? The same thing we do for kidney. So that's one. So we've mentioned this. So in terms of, remember I was telling you about headaches. Amlodipine can cause headaches. It can cause pain and swelling. So that's the one I want you to remember. So in terms of laboratory monitoring, we are not fussy about it. But if you come to the teaching hospital, we must write this for you. Some cannot afford it. And if they can't afford it, they come back, we still will treat them. We still continue to treat them.
Please, if you have a client that alongside this client is pregnant, and that client wants to register in a facility, what can we do? And the BP is still high.
Very good question. So if you have a patient that is pregnant, has he been in the program before? He has been in the program. If any person becomes pregnant in the program, you stop all these drugs. Good. You also register in your facility. Hypertension and pregnancy is not for primary care, except if you have a doctor there. Are you following me? That will manage, because in terms of hypertension in pregnancy, a complication, it can go anywhere. Eclampsia. Have you seen eclampsia patient before? You see the patient fit cancer. It's a horrible thing. Are you following? Yeah. So, it's not what we manage at that level, except you have a doctor. You have to save yourself the problem and say, go to another place. Because at that level, we change the medication. From animal studies, things like losartan is not safe. Animal, for the babies of animal, they didn't do it to human, but we translate it to humans. Hydrochlorothiazide is not safe because if you reduce the placenta perfusion, the baby needs that to grow. So if you are giving such medication, the baby can become retarded, what we call intrauterine growth retardation, IUGR. Are you following? Yeah. Amlodipine is safe, but in Nigeria we don't like using it. Are you following me? We use more of nifedipine and aldomen and labetalol and so it's not for that level. You have to refer. You have to refer that patient. It must be managed by a doctor. It should be managed ideally in secondary centers and tertiary centers by an obstetrician. It's high. It increases it, but the hydrochlorothiazide we are using is low dose. Yes. So most people don't have this. Okay, so yeah. Yeah. Is that taking consistent and increase your uric acid, yeah. Yeah. You know, if you look at our protocol, if you look at this protocol, you can see that it's only when you get to step 4 that you added uric acid. Is that not true? Yeah. And most times, from what we have found, most patients will be in control with step 1 and step 2 and step 3. It's only a few patients. The medications we got for step 4, you know what happened to them? You know, they were just redundant. Most of them, they were just redundant. And you know, and it is so because you are catching the patients early in the community. But if they're going to come to me to teaching hospital, they will need 5, 6 medications. As I'm here, people call. In fact, there's a matron I called. She's a matron in a private school in the city. One of their staff, their blood pressure was 200/120. She's on medications already, but it's not controlled through therapy. We just had to adjust, even on phone, adjusted it. The blood pressure has come to about 160/80 now. But she's going to be on like 5 medications. So those are the type of patients we see. Some of them on 6 medications to control their blood pressure. Are we following? But you are seeing them early, catching them early, before they get to that level. And that's the beauty of our community approach. So, I want you to value what you are doing. Are you following me? You are saving lives, value it, value what you are doing. Know that you are doing a great work. So, can you clap for yourself? You are not sure, you are not even clapping for yourself. If you don't clap for yourself, you will not clap for you. Thank you very much. That is wrong. Vasoprene is not antihypertensive medication. We give it for selected people. We don't use selected people. Because I saw a retired nurse, principal of School of Nursing, that had PCV of 10% from using aspirin. I'm serious. We didn't, in fact, we had to, when we checked, we say, is it that it's a cancer she has and everything? Upper GI endoscopy, we know that he has ulcerations from aspirin. We have to transfer that with like 3-4 pints of blood. She's fine. Aspirin. Aspirin is not enough, so you don't use for every patient. those that require it. And normally you use it, those that require it, you use it after food. You use it after food. People will say it's taking aspirin, it doesn't matter, it's not true. It matters. So please, don't use aspirin until it is necessary. We use sometimes for those that are diabetic, have high cholesterol, there's a way we risk. But at the primary care level, no. Anti-inflammatory. That's for a short period now. And we don't even use anti-inflammatory. We have diclofenac or that also. You understand? Yeah. Because its antiplatelet properties are bleeding and other things like that. So we have other things you can use. And please, all these ibuprofen, you can use them for short period. Because you know they are not safe for the kidneys, apart from the tongue. Are we following? Are we flowing? So please, this protocol issue, when we come to your place, we see them. We must see them, we must renew them. So as we are taking this, please put them there. It's so easy to use. Or is it not easy? One page is bold, everything. So what do you want again? And it's a way, the counseling is there, everything you need. Are we fine? Yeah. Any question? Any challenges in it? Can we continue? Yeah. Okay. So we have some exercises. So I'm going to hand over to my brother Nick to come and take over. Exercises and so after we have to go to let's clap for Dr. Ojji.